She's just taught here at Duke. You've been here for almost a year now, and she has her PhD in health services research, right? So this is going to be a little bit different, I think, than what we have heard from so far. But just yet another area of HIV research, and she's also been involved in all three aspects of our grant. One of the aspects is the internship. So after today, you'll have participated also in parts of an internship. So thank you so much for your involvement, and looking forward to your talk.
Thank you. I appreciate being here today, and I'm glad I can talk to you about my research. So if you have any questions, please let me know. And yes, as Lauren said, I'm a health services researcher, and I do mixed methods, so I use qualitative and quantitative research. And currently, my research focuses on telehealth. And I'm particularly interested in how telehealth could be tailored and implemented to improve equitable outcomes in HIV care. So to give you a brief overview of telehealth, this is a general overview how telehealth was used pre-pandemic, during pandemic, and post-COVID-19, or at least post the pandemic stage of COVID-19. This is from Epic's Cosmos database, and it shows that peak of telehealth here in the beginning of the pandemic. Pre-pandemic levels are close to zero or zero for some disciplines, and then it trickles down after this big peak and levels at below 10% of care encounters as we head to the post-pandemic stage of COVID. In infectious diseases, they were actually comparably high in the comparison of specialties, but we still see we have that peak here, and then it levels down and kind of almost disappears after the pandemic. Why should we care about telehealth at all in HIV care? The benefits are that it helps improve the continuity of care during the COVID-19 pandemic. It reduced the transmission risk of COVID, especially among people with HIV whose immune system may be impacted by their HIV status. It reduced stigma and improved the privacy. When people didn't have to come to the HIV clinic, they were not at risk that somebody sees them walk in or sit in the waiting area and get their status involuntarily disclosed. It reduced transportation barriers and costs. People didn't have to come in here, which often is a big barrier for some people, especially if they live farther from the Duke or any larger medical center. It also improves the convenience and flexibility, especially for people whose work schedules may not be super flexible. Having a televisit that takes 20 minutes and they can take it from anywhere with an internet connection may help people to get connected to care and overcome some of the barriers and issues with scheduling in-person care. For the providers, it gave them a wonderful new opportunity of looking inside what the patient actually, what their environment looks like. Where do they live? How do they live? How does their normal life look like? And it gave them some information that also is important for their care, thinking about HIV care beyond the medication, but the social and other aspects of care that people with HIV may need and would benefit from. So I structured my previous research into quantitative research, where I used electronic health record data to assess telehealth use and who used it. Because what we know is, while telehealth may be a great option for many, it was not used by everyone equally, and I'll show you later who particularly used it or did not use it as much. Then I did qualitative research where I talked with people with HIV and HIV care providers to assess their experiences, to learn what went well, what didn't go so well, and also how they decided whether telehealth or in-person care was the right care option for them. And then I do preference research using customer scaling and discrete choice experiment methodology to assess telehealth preferences, and that also helps with identify who should be getting telehealth and who would benefit more from in-person care. First, let's talk about the quantitative research. A couple of quick study facts. We did a retrospective observational study design, and we used aggregated electronic health record data here from Duke's Clinic 1K. We extracted that data with Epic Slicer Dicer tool, and we included 18,000 and a couple of visits that were provided to 2,600 patients, and over the study period from January 19 to March 2023. So the analysis of aggregated data was fairly limited, so we did a graphical analysis of variation in HIV care over time by a couple of main variables of interest that included age, sex, race, and ethnicity, and we did a proxy for distance to care. We looked where people resided and stratified or looked at the differences by people who resided in the same county as Duke 1K, which is Durham County, and people who lived elsewhere. We also did some chi-square tests to examine variation in viral load testing and outcomes at a later time based on the visit type patterns in the first year of the pandemic. And I'll show you a little bit more about that. So first, it looks fairly similar here at Duke as it looks in the overall graphic by all or by many, by 222 medical centers using Epic. What we see is we have that huge peak, and that peak was higher here. It accounted for about 88% of visits were provided through telehealth in April 2020, but we then see it trickle down to about, and that is the average of 2021, June, moving forward in our data set to 9 patients later on per month that are seen for telehealth. And we also see that telehealth was not equally used by everyone, so we looked at differences by race and ethnicity, and I want you to look at those 3 different lines. The blue line is non-Hispanic white people, the red line is non-Hispanic Black people, and the yellow line is people whose race and ethnicity was not specified or was other than non-Hispanic white or non-Hispanic Black. And what we see here is that just in the beginning of the pandemic, so we see that there was a pandemic-related decrease in visit rates. And we also see, when we look at those trajectories, that dip was largest for white people with HIV. We then looked at the proportion of people with HIV who had it, and later on we look at the quarters. So bear with me here. And what we see here is that the average use of telehealth was highest among non-Hispanic white people with HIV. When we look at age, we have the red line, which is people who are 50 or older, and the blue line for 18 to 49-year-olds. And we do see that the pandemic-related decrease in visit rates is much more pronounced for older people. We actually look at that blue line. There is some variation, but on average, it kind of moves fairly smoothly through the pandemic, so there was not that much of an impact for younger people. And when we look at telehealth specifically, we see a very surprising result here at Duke, because we see that older people use on average more telehealth than younger people. That is something very interesting to us, and that is counterintuitive, and also so conflicting with a lot of the other literature, where we see that younger people are usually using more telehealth. So we're trying to learn more with individual level data to understand what explains that we see older people using more telehealth on average. Then we looked at differences by residence, and the blue line is people who live in Durham County, and the red line is people who live in another county. And we do see that in the beginning of the pandemic, the visit rate decreased for both populations and stabilized later on at a slightly lower level. And when we look at telehealth, we see exactly what we expected. We see that the proportion of patients who receive telehealth was higher among people living in a county different than Durham County, which is a very, very weak indicator that potentially distance care may be important, and we look for more individual level data and more resident data that is more accurate or more detailed than the county of residence to see that actually may be something that drove that. Then we also look at differences by sex, and we do see that there are no significant differences between females who are represented in the blue line and males who are represented in the red line. Females started a little higher, they converged after the pandemic. And when we look at telehealth, though, we do see that female people with HIV use more telehealth than males. Now, what we also were interested in was that first visit after the onset of the pandemic. Our reasoning for that is that HIV care has to be continuously provided and medications have to be continuously taken to be efficient and effective for individuals and for their societal benefits. So it is important that people receive their care continuously throughout the pandemic. So we looked at that first visit, which we assumed that would be an indicator to see whether people postponed their care at the beginning of the pandemic or not. What we saw here is that 94% of the whole patient population that we included had a first visit after the pandemic, but that also includes people that may have moved here and started new, or that may have included people that moved elsewhere. So they are not necessarily lost out of care. They may have just moved elsewhere. And when we look at telehealth and how that was used for that individually first visit after the onset of the pandemic, we do actually see two peaks. We see that first one that is in line with what we see the overall telehealth utilization. In the beginning of the pandemic, 88% of all visits, and that included the first visit per person, was 88%. And then what we interestingly see is that there is a second peak later on in the pandemic. And I have to caution you with the overall cumulative rate of visits, the numbers get smaller, but we do see that increase, and we do have a couple of theories how that could potentially be explained. One of them is there was another increase in cases around that time here in North Carolina, which was potentially explained by people said, okay, let's switch over to telehealth more. And another one could be that telehealth helped people to connect and reconnect with care who may experience a lot of in-person care barriers. Then one of the important factors of HIV care is always monitoring those laboratory values. Most interesting, I would say, is the viral load, which we want to be very low and potentially suppressed, which we defined as less than 200 copies per milliliter. And we wanted to see if there's a variation in that viral load testing uptake and outcomes based on this. So we group people into that first group who used in-person care only in the first year of the pandemic, people who used a combination of in-person and telehealth care, and people who used telehealth only in that first year of the pandemic. And we looked at the viral load in 2022 to see if there's any association that we could find in that aggregated data. So first, the good news is if we look at people who had unsuppressed viral loads, which means 200 or more copies of the virus in a milliliter of blood, we see that the proportion is fairly equal and did not differ by the visit patterns. But the big cautionary lesson that we learned is when we look at people who did not have a viral load test recorded, we see that people who use telehealth only had a higher proportion of not having any tests, and that was statistically significant.
question.
Yeah.
Sorry, going back.
Sorry.
For the people who telehealth only, that's telehealth after the pandemic, so was their viral load, the ones who had one, was it like in the early part of the year?
We did not look at, so we look at the visit type patterns in the first year of the pandemic. So March 2021,
Okay.
February 2020, March 16, 2020 to March 15, 2021, that first year.
So then the 60% of people with telehealth only came in at some point and just had labs done. Is that?
They had labs. So
I guess I'm
So
trying to.
it is 70% of people who had labs done in 2022 who only received telehealth, because it is among the people who had labs done, they could be always suppressed, which is the red bucket, or they could have had at least one unsuppressed blue bucket test.
Okay.
The yellow one is people who did not have any test recorded
Gotcha.
in the Duke system.
Gotcha.
So, yeah, we did test for the difference in having done a test at all versus not having done a test, which was significant. And then we also tested the sum of the red and blue buckets across those different telehealth uptake patterns, which differentiated between suppressed and unsuppressed among people who had tested, and that was not statistically significant. So what we see is that this bucket really is a problem for HIV care, and we did find that the chi-squares were significant to support that significant level. So in summary, telehealth was heavily used at the beginning of the pandemic. It was unequally used by some people with HIV, and it may be used to achieve viral load outcomes comparable to in-person care, but we have that cautionary tale of we have to have this viral load test. Even if people use telehealth, there are different strategies to achieve that, and we could use telehealth for people especially who have barriers and challenges coming to in-person care to make care as easy as possible for them.
So, do you know how much of the telehealth was initiated by the provider's office versus the patient?
We do not. Unfortunately, we do not know that. It is not recorded in the HR field who decided or who initiated. What we do see and what we did as part of our qualitative research was trying to understand who made those decisions and what characteristics and factors were considered when making those decisions. Based on the pandemic as a very special time in our lives, we do know that at the very beginning with public health policies, there was very little agency on either side. Oftentimes it was a clinic or organizational decision to some clinics closed entirely, others really pushed to do everything that doesn't have to be in person to telehealth. And that kind of is difficult to assess, even if we know what people considered when making those decisions. If the clinic says nobody comes in, it is not necessarily a true decision that was made by patients and providers. But I would love to have that data. I think it is very interesting. And as we move to the post-pandemic stage, I think there is more need from both sides. But yet there is still not very good systems in place to facilitate that, what we always want, shared decision making, where we bring people together and find the best solution for everyone. Unfortunately, the way how visits are scheduled, it is very difficult. Usually either a patient calls, but they never speak to their provider. So it is a patient with scheduling agent consideration or it is then a provider reviews and approves or denies telehealth visits. But that clear and direct communication between providers and patients currently is very difficult to facilitate unless the provider picks up the phone and says, okay, let me call that person and try to learn why they want to do telehealth or the other way around.
Do you know if a person can schedule in my chart the telehealth visit in this HIV clinic? Because I know sometimes you can, sometimes you can't, but.
That's a good question. So theoretically, yes, but I know that some people do struggle doing it.
You're right.
So
I'm just wondering if there's like data there that you can see, well, in my chart, this person scheduled the telehealth visit. I don't know.
that's a good idea.
Good idea, thank you. These are all people living with HIV, right? They're not people coming to the prep clinic.
Those are all people with HIV. All right, let me tell you a little bit about the qualitative work that we've done. We did semi-structured in-depth interviews with 18 people with HIV and 10 HIV care providers from Prisma Health Immunology Center in Columbia, South Carolina. We did all of them between July and December 2022, and we had a little supplemental survey to get some demographics and also a couple of insights in how they perceive what their attitudes are towards telehealth. We did thematic analysis and line by line coded all of the interview transcripts, and then used a grounded theory approach to synthesize the data and the results that we got from those interviews. One of the big areas that we were interested in was those barriers to telehealth. While we want to see telehealth as a bridge to bring people to HIV care, we also know that telehealth and the implementation without a plan in the pandemic was not optimal for many. So what we saw was technological barriers. Some people struggled with getting access to internet based on where they live or based on what they can afford. They struggled with access to technology, especially as we wanted to use video visits and not only voice-only visits. And also people struggle with digital literacy in using those devices and internet connections to get care. We also found there were barriers related to the virtual nature of telehealth, so that new way of getting care or providing care for the providers was not easy for all of them to adjust. Especially in the beginning, there were a lot of communication barriers listed, but also a lot of, especially people with HIV, said that it felt impersonal as compared to being in the room with their provider. It was just not comparable in that way of how they feel connected with their provider. There were administrative and regulatory barriers. So in the beginning of the pandemic, there was a policy change that all health insurance had to cover telehealth. Unfortunately, that still caused a lot of problems on the provider side. In the beginning, there were not many workflows, how to document and how to bill for that properly. But also, as the pandemic progressed and the policy support trickled down, it was more a individual decision based on the individual patient's insurance status and plan, whether it was covered or whether there was copay involved. What we saw is that all of those barriers were more pronounced among people with a socio-demographic profile that indicates barriers to care and that may indicate difficulty accessing care. For example, older people were more prone to have barriers with and challenges with digital literacy. People who live far away and in rural areas were more prone to have difficulty accessing a stable internet connection. Those are all not surprising, but it always gives us that alarming system, like if people who struggle to come to in-person care for whatever reason, they may also be the people who struggle most with accessing telehealth. So we always have to be very careful and considerate of making sure if telehealth actually benefits everyone, or if there are groups that benefit more or that have more challenges accessing it. Now, I'll talk a little bit about the decision criteria. We found 4 different domains. The first was patient-related criteria. That included preference, convenience, the fear of status disclosure and their perceived stigma of going to the HIV clinic, transportation barriers, and their individual fear of getting COVID. We also saw clinical criteria, so people who needed a physical exam or people who felt that they needed to be examined by their provider. That also factored into that decision whether they wanted to do telehealth or in-person care. Providers cited that the care history, comorbidities, their general health status, the time on antiretroviral treatment, and the time since the last visit also impacted their decision if a person was able to do telehealth or needed to come in person. And on the provider side, there was also provider preference as a factor that impacted those decisions. And those were all, as they were reported, fairly similar in their level of hierarchy. But what we then saw is that care continuity was the main driver that superseded other factors. So in qualitative research, a lot of people reported that potentially telehealth wasn't their preference, but to make sure they stay in care, they did it to achieve that care continuity. And the same on the provider side, we heard providers say, like, I really wanted to do a physical exam on that person. They would have benefited from it. They were not able to come in. So to make sure that I did speak with them, that they are on track with their medication and care, I did agree to telehealth. So that care continuity was a superseding factor for those decision criteria. We also looked at a couple of attitude questions, how people value telehealth, and the green side of the bars are positive attitudes and values, and the red ones are negative ones. So we did see generally there was some heterogeneity. There were people who liked it more and people who did not perceive it as beneficial. But in general, attitudes were fairly positive. And what we do see, as we also found in the qualitative work, that patient-provider relationship part, that it feels impersonal, it feels like there's something missing, was also shown to be more negatively perceived.
Yeah. Do you know what the relationship was between patient and provider prior to the telehealth? In other words, are they seeing different people all the time, or are they seeing the same person that they may have seen in person?
So generally speaking, they usually see one provider throughout their care, but there may be switches, and especially with telehealth, that is one of the doorways to switching providers. If there would be potentially a provider who doesn't want to do telehealth for whatever reason, a patient may switch to another person to do telehealth. In the beginning of the pandemic, where there was no choice for anyone because of social distancing policy, we don't have the data to prove that point, but we do not expect that to be a huge pathway or transitioning to another provider. But it is a very good question, and we do now want to get like that general perception of their relationship, because some people may not have had a good relationship with their provider, regardless of type of care. Yeah. All right, so in summary, people with HIV and HIV care providers face diverse barriers to care. There was a multi-criteria shared decision process to determine which visit type, and we think that shared decision making is needed to make sure that everybody's needs are properly met. And overall, we saw that positive attitude towards telehealth were reported on both sides, providers and patients, but also we have very small numbers, so we definitely need more quantitative research to assess those attitudes. Let's now move to preference research. So I am a preference researcher by training, but I know that some of you may not have heard of preference research methodology. So I'll give you a very quick overview. It is founded in economic and econometric theory, especially random utility theory. It includes various methods. There are many different methods to assess preferences. And I think the ones that everybody knows is asking people for a rating. For example, how important is factor X, very a little or not. And then there's more elaborate methods to overcome some of the difficulties in interpreting that data. Preference research, and especially the best first scaling and disparate choice experiment, are tried very much explored and used for a long time in environmental, transportation, marketing research. And they also have been used in health research, I think for at least 30 years now, but they are still not as commonly used. And oftentimes the type of question is new to many people. And I'll show you those questions later. So the general anatomy of the preference experiment, and I'll think of buying a new phone. So the problem definition or the research question is first complex. There's many different options and many different things that can be considered when you want to purchase a new phone. What we do is we decompose that decision and break it in smaller parts. So one is the price. It can be $1,000 and it can be a couple $100. Another one is the brand. I know some people feel very strongly about iPhone. Others may very much focus on buying whatever other brand there is out there. And it can have other things like whatever, the quality of the camera or whatever is important to you and your specific need of using a phone, the size of the screen, based on what you want to do with it. So we say, okay, decompose that big, complicated decision into those smaller pieces that impact our decision. And then we design a questionnaire by varying those features based on an experimental design. So we now come up with hypothetical options of how a phone can look. For example, it can be an iPhone that is only a couple $100, that has the best camera and a large screen, whatever your need is, whatever your most preferred option is. And some of those are more realistic, others are not. But what we do is with that experimental design, we vary that strategically. So when we then ask you to make multiple decisions, like would you buy that hypothetical option A or B, we can then, after having many decisions observed from many people, we can then calculate each of those different factors, how important they are. So I can tell that, for example, the price is double as important as the quality of the camera on average, and we can then also drill down into different groups how preference patterns may vary. So we did a best score scaling type 2 profile case in South Carolina with people with HIV in 2023, and we used baseline scores, and I'll explain a little bit later to analyze that data. To understand what features of telehealth are important. So you may ask, what features are there? And we considered scheduling as a group of features, which could be either scheduled by phone, scheduled by MyChart, or you go to a virtual clinic where you log on to a website and you don't have to schedule, you just wait for the next provider who is ready to see you. The next bucket of features is telehealth type, which could be voice only, using video, or using video and a telehealth exam kit. That is a little box that can help, that has a couple of cameras, so the patient has it in their home or wherever they do telehealth, and they can have the provider look in their throat or ears or nose. It can look at rashes. It can actually record heartbeat and breathing sounds. It can do a couple of basic measures that may be important for clinical decisions. Then, where do people get their labs? Do they have to come to the HIV clinic? Can they go to a local lab close to their house? Or can they potentially get their labs at home? Thinking of dried blood sampling, they could collect a blood sample and send it to a lab. So, and then another factor was, who are they seeing for their visit? Do they see their regular provider who they know that they usually see, or do they see anyone who's qualified to provide HIV care? Then we wanted to also see a couple of add-on innovations, how we call that bucket of features. Qualitative work, especially with that feeling impersonal, that might take out rush. So we said, okay, if time is a problem, we can add a couple of minutes in the scheduling to make sure that people have time to talk with their provider, let it be about medical care or anything they want to share about their life. We included a feature where people could get a device to telehealth with from the clinic or insurance. We added an option to have a multidisciplinary visit where people in their telehealth visit could also see the nurse, the pharmacist, the case manager, the social worker, whoever is involved in care and may contribute to their care during a telehealth visit. We included having access to a chat hotline if things don't go our ways and there were any connectivity issues. And we added that option where people were allowed or had the option to go somewhere else to do telehealth, for example, the library, in case they did not have internet at their home or did not have a private space in their home. So we constructed different telehealth options, and that means a combination of one feature of each bucket per question. And this is how the questions look. So you have one scheduling, one telehealth type, one feature of where to get your lab, the provider is defined, and then one of those add-on innovations, as we call them. And we ask people, out of this option, which of these features do you like best and which do you like worst? People saw 10 questions each out of these, and so we got the data to calculate how often was each feature chosen best minus how often was each feature chosen worst. And that was weighed by the amount of times it was shown in the survey. And I think you have a question.
Can you go back? I'm kind of confused about the data collection. So these aren't all under the one bucket. These are like a different feature for each bucket.
Yes. So
can you explain like this a little bit more?
Yes, I can. Thank you for asking.
Okay.
So here, the top line is the different buckets first. And then underneath, we have the different features, how each bucket can be described. Mm-hmm. We now take, based on a experimental design, we combine one feature of each bucket, which we say is, that is your telehealth option. Mm-hmm. So this is one question, but people saw 10 different configurations of a telehealth option.
I see.
So all of these features, or some of these features, vary per question.
Okay.
And all together, we also blocked our design. So we all together, I think we had 60 questions that were defined by that statistical design to give us good main effects after analyzing it, giving us good combinations. We then, every person was shown 10 of those questions so it doesn't get overwhelming. Because as you look at that question, after a while you're like, not all looks the same to me. So we do have a big consideration when we design those experiments that we take into consideration that fatigue and that those questions are fairly cognitively difficult to answer, and if they actually consider all of these different features. And what we also see is some people care most about one specific attribute, and I'll show you what was most important here.
Sorry, one more question.
Yes.
So each person might get a different set of kin, and those were randomly assigned?
Yes.
Okay, yeah. I'm with you now.
Also, anybody else having any questions? I know that I'm assuming that most people have not done a best first scaling experiment before. All right, so we're now calculating the best minus worst scores, which is the preferred option to analyze the data. Other strategies can be used where we subtract how often something chosen as best minus worst. We take into consideration that some of our buckets had more features, so they were shown less often, so we'll wait for that, and then I force it to be positive and between 0 and 1, just for us to look at it nicely. So I force those values to be between 0 and 1, and 1 shows that this was the most important, the best feature was seeing their regular provider as compared to seeing any qualified HIV care provider. And the worst feature out of these is the option to go to the local library as compared to having extra time with your provider to chat. So in each of these buckets, we have one best feature, and I want to caution you when you look at that. So it looks a little bit like, oh, the option to go to the local library was the worst feature compared to the others. Think of it like candy. Everything can be amazing, but some is better than others. It does not give us any information whether some were perceived negatively or disliked. It was just worse compared to the other features. And what we do then is when we combine those in our study, we found that based on the features that were included, that was the best telehealth option based on the average values that people gave, which included scheduling telehealth by phone, seeing the provider for video, getting blood drawn at the HIV clinic, seeing a regular provider, and having extra time to chat with the provider. So the next step, we are not done yet with identifying and really tailoring telehealth to the needs of patients, but we have some good information to understand how people feel about it, how it was implemented, and where are the challenges. So now we need to identify telehealth candidates. So in the pandemic, lots was decided from policy and organizational decisions to prevent COVID, but as we move in the future, we want to identify people who would benefit from it and who are willing to use it. So we don't want to push it on everyone as it doesn't result in good care. We want to learn how to improve telehealth options to understand what is liked, what is disliked, and then also to make sure that the telehealth option that is offered to people actually meets their needs and expectations. We want to make sure that it works, so we definitely need to always monitor our lab values, care satisfaction, and other measures to make sure that telehealth results in good care outcomes. And we need to improve the implementation strategy because the key to all of this is knowing who needs what and then making sure that they actually get it, which is not always as easy as it sounds in a clinical workflow that is often very much standardized to make sure people get the good care that they need. So what we do is do an discrete choice experiment. It's also one of the preference experiments that gives us more data to identify average preferences. One of the very good things with the DCE, the free choice experiment, we will be able to identify positive and negative. So there is a natural zero. So we can see which is positively perceived and which negatively impacts decisions, which is negative. By people, it helps us understand the willingness to use telehealth, and we can also assess preference heterogeneity because one size does not fit all. That also is true in HIV care and in telehealth and HIV care. So there may be different distinct buckets of preferences. And if we know them, if we can classify people, we can also make sure that they get their best option. So we updated our list a little bit. It will still include our 5 buckets of telehealth features, but we try to limit a couple of those features, and our disparate choice experiment questions look different. They now have 2 hypothetical options next to each other, and we'll ask people, would you want to do option A or option B? We now do not ask about the features, we ask about the overall decision, which at least in theory, makes people weigh all of those features that are described within one option against all and the combination of features in the other option, which gives us a little bit of more information how people trade off those features. There may very well be, for example, if one feature, if it is super important to see a regular provider, which was the most important feature in the best first scaling, people may be willing to trade off something. And with this type of experiment, we can get to those trade-offs. So that doesn't give us yet information whether they want to do telehealth at all. So what we do then after the experiment, those are not experimental questions. We now say, okay, let's look at a standard telehealth option compared to in-person care. Would you switch? If they prefer in-person, we ask your individual choice of best features. Would you do that telehealth visit as compared to your standard in-person visit? And then we'll also incentivize this by adding that next feature saying, with the in-person care, you have to pay your usual out-of-pocket care. Would you change your mind if I would say telehealth was free of cost? To understand what is driving those decisions and get people classified into different willingness buckets of using it. We then use Latin class analysis to identify subgroups of preferences. We assume that there may be differences based on their individual needs, and that will help us. We will then do a telehealth needs assessment with more qualitative research with providers and patients to understand the barriers, what keeps you from doing telehealth, and facilitators, what helps and motivates you to do telehealth. And all of that will come together in the future when we have all that data to develop those implementation strategies to help clinical decision-making processes, to help making sure that if there is somebody who would benefit from telehealth or in-person care, that they get the care that they need. I have acknowledgements. Our studies were funded by a couple of different grants. And special thanks to my mentors and all the study participants who shared their experiences and information, and our collaborators. So thank you for your attention, and I'm happy to answer any questions that you may have.
Okay, so the telehealth is limited to people like the United States, or it's what is going on like all over the world? And of course, like what I'm saying, I see that it's more like it makes free access and easy access to communication and all that, like meeting with your for your healthcare and all that. But can it also cover for maybe emergency case, like maybe there's an emergency case? So, and for people, maybe like for people in Africa and places like that, is there a kind of system that would like lecture people on how to like handle telecare? Maybe they are interested in using like video, kind of video and all that. So is there any like, because there are some people that they are not really used to smartphones and all that.
Yeah, that's a great question. And I think the answer is yes and no, kind of. So this study is limited to North and South Carolina. The information I showed you, the qualitative and the preference research was done in South Carolina, and the HR data, I only showed you the North Carolina part of it. And surprisingly, even there, things are very different from North to South Carolina. Telehealth has been used certainly much more with the pandemic all over the world. I know that there is some studies in African countries who also explore that, specifically in HIV care, but also across disciplines. So with the discipline disconnect, we do see that behavioral health in particular uses a whole lot of telehealth, while many other disciplines do not use it, especially you mentioned emergency care. I think they are not necessarily very high on the use rate, and that may be also connected to that need for in-person intervention. Thinking of emergency care, but it can be differentiated between accidents and their care versus acute care needs. And there is definitely a space for telehealth, because what we did see with the pandemic, everybody who had respiratory symptoms was more encouraged to do telehealth to make sure that they don't spread any kind of infections to others. So it really is, there is a huge potential for scaling that up to other care settings, but it would have to be very much resource, environmentally, and culturally tailored, because there may be some differences. I do work in a study using text messaging in Tanzania to encourage HIV testing. And in our formative research, we found that people were recommending to use phones or dumb phones as compared to smartphones because of how the ownership distribution is. So especially in some countries, video may not be a good option if people mostly have phones that don't do video. So I think it is very much a good avenue to think how it could be used elsewhere, but it always has to consider the internet and technological setting of that environment. And that is not necessarily limited to African countries. That is the same in rural South Carolina. Internet access is much different to Durham, North Carolina. So I think it's always important to make sure that what we offer is actually feasible, and then it could be a great opportunity. Another opportunity is provider to provider. We're oftentimes in rural health care settings, regardless of the country, maybe there is no HIV care specialist there. So to make sure that they get optimal care, we can just zoom in a provider from a larger medical center to advise on that case and making sure that the patient gets the best care possible. So there's many different options how telehealth can help in different resource settings, because usually still, even if individuals may not have great internet access in a rural area, a health center or a whatever healthcare setting may have better infrastructure to facilitate that. So it's not technically telehealth for the patient, but it would still be telehealth for the provider-provider interaction. Any others?
This is like very specific, but in order to do telehealth, you have to be like typically within North Carolina. Did you see if there were any patients that live in Virginia and South Carolina? They can't do telehealth. Did you see if anyone who comes to the HIV clinic is from out of the state?
We do have county level data, so we could identify counties outside of North Carolina. It is a big issue with that licensure problematic. During the pandemic, they were also a little bit more lenient. There were some rules. As long as they resided in North Carolina, they could do telehealth potentially outside of North Carolina, but it is very difficult. Licensure usually says the patient has to be in the state where the provider is licensed to provide care in. I would hope that with that big transition and more openness in policy for telehealth, that it could also implement some flexibility there to allow people to have continuous care after they moved or when they're on vacation or whatever may happen. But yes, we could have that data and look at that. And then the visit type will still tell us whether they did in-person or telehealth care. But we do not have IP addresses for visits, so we could not say where they actually were for their visit.
Thanks again.
Do you want to